Okay, start recording on this. Go ahead and state your name.
I am Dr. Tarek Hassanein, Professor of Medicine at University of California, San Diego, Medical Director of Southern California GI and Liver Centers. Today I'm going to talk to you about primary biliary cholangitis, PBC, considering the diagnosis and the treatment options that we have. It's a program sponsored by Chronic Liver Disease Foundation. Just a reminder, recently the PBC term has changed from primary biliary cirrhosis to primary biliary cholangitis, because a lot of our patients that we currently see don't have the cirrhosis part yet. But just as a reminder, this is a chronic cholestatic liver disease, has an autoimmune etiology, and it is very characterized by specific type of inflammation and destruction of the small interlobular bile ducts. It affects predominantly middle-aged females, although we see young females and elderly females affected by the disease, and there is a rising incidence and prevalence. How we diagnose PBC? The main criteria for diagnosis, any one of the three criteria. A patient with an elevated alkaline phosphatase, and when we talk about elevation of ALP, it is equal or more than 1.5 times the upper limit of normal. A positive antimitochondrial antibody, AMA, or a liver biopsy that shows destructive cholangitis of the bile ducts with non-suppurative type of destruction. So any of these two criteria help you to diagnose PBC. Commonly we diagnose it in patients with a positive AMA and patients who present with elevated alkaline phosphatase. Now, this is the majority of the patients. However, we have some types of PBC that look a little bit different. We call them variant syndromes. We have a class of PBC patients who are AMA negative, although the majority are AMA positive, but there's a group that presents with elevated alkaline phosphatase and their AMA is negative. And you will find out that 50% of these people have a positive ANA, a positive antinuclear antibody. And if you subclassify the ANA, we specifically find the anti-GP210 and the anti-SP100 as the subtypes of the ANA that we commonly see in the PBC AMA negative patients. They come with the same clinical presentation, and they tend to have reduced survival on long term. Another variant is the overlap syndrome, and from the name you can imagine it's overlap with another autoimmune hepatitis, and you can find these patients when the transaminases are elevated, yet in relation to the ALP, that ratio is less than 1.5 times. We find it in patients who tend to have elevated transaminases with elevated IgG and a positive smooth muscle antibody with a titer above 1 to 80. And then there's this rare condition. It's not very rare. It's 5 to 10% of our patients who have a very fast progressing disease. We call it premature ductopenic variant, very rapid onset of ductopenia. Accordingly, the patient develops cholestasis, icterus, moves fast to cirrhosis, and that's a group of patients that tend to go to transplant early. So on the clinical side, how it presents, most of the patients, they are asymptomatic. Although when you start talking to them about the symptoms, they might say, yeah, I am experiencing itching, fatigue, dryness of the eyes, dryness of the mouth. So 60 to 70% when you meet some of these patients, they are asymptomatic. However, symptoms such as pruritus, fatigue, and Zika syndromes are the key symptoms. So if I have any if I have any patient with abnormal liver enzymes, particularly alphas, and I ask them for pruritus or fatigue, and they mention they have it, you need to screen them for PBC. Almost up to 10% of the patient present already in cirrhosis, and that's what we call them PBC, and not only the cholangitis part. And some of these patients actually present with complication of portal hypertension. And it's interesting, specifically in PBC patients, you might see a bleeder or ascites in the patients even pre-cirrhotic. So how we manage these patients? We get this patient, we now diagnose the patient with PBC, we do the initial evaluation. What's the initial evaluation? We need to do some imaging and labs. We assess the symptoms that we talked about, pruritus, fatigue, Zika syndrome. We stage the disease of fibrosis. And knowing that this is a disease that affects the bone, it is very important to get a DEXA scan, a bone mineral density estimate. Once we diagnose PBC, alphos is elevated. Our first line of therapy is orthodeoxycholic acid, UDCA. Very important to remember the correct dosing is 13 to 15 milligrams per kilogram per day. And once we establish the diagnosis, start the patient on treatment, then I need the long-term monitoring. I need to see if they are responding to the treatment. I need to do clinical evaluation on a regular basis, make sure when they are getting to cirrhosis or they're already at the cirrhosis stage. We can use some of the models like the Mayo risk score, and if it is above 4.1 or they have thrombocytopenia, then we are talking about advanced cirrhosis, getting closer to transplant. And accordingly, we do what we always do for cirrhotics, which is endoscopy, looking for varices, and liver cancer surveillance every 6 months. We monitor the patient biochemistry. We already started them on UDCA, and we need to figure out within a year, are they responding or not? And that year point is very important for us, because in some patients it takes that long for them to respond to UDCA, and we have a number of risk stratifications that we can do at 1 year of therapy. And accordingly, if the patient is not reaching my goals of therapy, then I need to consider for adjuvant therapy. And recently, with the availability of elastography, we look and monitor the patients for elastography. So what's the first line of therapy? We already talked about orthodeoxycholic acid, UDCA. It's orally administered. It's naturally occurring type of a bile acid. It's a hydrophilic secondary bile acid. The correct dose is 13 to 15 milligrams per kilo per day. We see improvement in liver tests, and it is seen and detected within a few days, and 90% of the improvement usually occurs within 6 to 9 months, but we tend to consider 1 year of treatment before we make the next move to use adjuvant therapy. The number of patients that respond within a year of treatment using orthodeoxycholic acid is around 65%. This has been reported using the Paris criteria, and they reported 66% response to orthodeoxycholic acid, and the Barcelona criteria, they reported 62% response in 1 year of treatment. This means we have 40% of our patients who end on orthodeoxycholic acid with a suboptimal response. So what does orthodeoxycholic acid leads to? if I give the right dose, the 13 to 15 milligram per kilogram per day, I would see an improvement in the total bilirubin, the alk-phos, the GGT, the AST, and the ALT. There's slight improvement in cholesterol and IgM. There's a delay in the histologic progression of the disease, which means delay in the development of portal hypertension and varicose varices, and an improvement in survival without a transplant. So these are the therapeutic effects. Now, I would like to remind you is risk stratification in PBC, various response criteria. We have the Barcelona criteria, the Paris criteria, the Rotterdam criteria, Toronto, Mayo, and all these criteria, all these ways to look at stratification use continuous variables. The alk-phos, the AST, total bilirubin, the albumin. APRI can help you out. There's a number of mathematical models, the Mayo Risk Score, the Globe PBC score, the UK PBC score. So these are more sophisticated modeling of several variables in equations that you can access on your computer. Just to remind you that the Globe PBC score and the UK PBC score, you do that scoring after 1 year of treatment. So, for example, the Globe score, you can get it online, and when you look at it, it involves age of the patient at initiation of orthodoxycholic acid. Then, at the point of 1 year on treatment, the total bilirubin, the alk-phos, the albumin, and the platelets, all these are important for that calculation. And that calculation can predict the 3, 5, and 10-year survival compared to age-matched population who doesn't have PBC. Okay, if my patient doesn't respond, what is my second line? It's obetilocholic acid, the OCA or OCA. It's an FXR agonist. What does FXR agonist do? It has a choleresis effect. What is a choleresis effect? It makes your bile acid secretion increase. There is decrease in the bile acid absorption and recirculation, decrease in the bile acid uptake, decrease in the bile acid synthesis. Choleresis, getting rid of the bile acids. It has effects on inflammation pathways. It downregulates NF-kappa B, TNF-alpha, the CRP, and so on. And we'll talk about this in a little bit. OCA came into PBC and approval recently after the FDA approved it for PBC. And it came out as a result of the POISE study. And the POISE study took patients with PBC who were randomized either to placebo or OCA 10 milligrams or OCA 5 milligrams for the first 6 months, and then these patients were randomized to continue on 5 milligrams if they are responding and have no issues, and if they are responding and they don't have pruritus. Now, if the patient is not responding and they don't have pruritus, their dose would go up to 10 milligrams for another 6 months. At the end of that year, that group of patients was randomized, and that group of patients actually went on an open label of OCA 5 milligrams the first few months, and then OCA 5 to 10 milligrams, and adjusting the dose according to tolerance. So OCA was titrated at 6 months. So the subjects who were titrated from 5 milligram to 10 milligram at 6 months, they met any of the following criteria at month 6, which is the primary endpoint that was not achieved. Their alk-phos didn't improve to below the 1.67 times the upper limit of normal, which comes around to 200. And no evidence of tolerability issues. Okay, so let's look at the data. When you look at placebo, it's in white. obeticholic acid, OCA, is in orange at the dose of 5 milligrams, and the dose of 10 milligrams from day one is in blue. And it's very interesting, from the early beginning and within the first 3 months, there's a difference between the 10 milligram and the 5 milligram, and through the entire course. But the 5 milligram in the patients who continued on 5 milligram, by month 12, they were doing as well as the 10 milligram. After that phase of the study, during the open label phase, it is very clear that the 10 milligram again gives you a little bit more response than the 5 milligram. And if we try to plot the alk phos, here's over time. You can see here the white again, the white circles is the placebo, and there's a significant difference. There's a significant difference between the placebo and the 10 milligram dose, and definitely the 5 milligram. There's improvement in the alk phos, not as much as with the 10 milligrams, although by month 12, as we said, they are actually look to be close to each other. And if we maintain the patient on OCA over the next 12 months, their alk phos continue to be down below, around the 200 or even below the 200, achieving the goal of less than 1.67 times the upper limit of normal. So definitely compared to placebo, and when you take placebo patient and you put them on the 5 milligram, they start improving. And if you adjust them, if tolerable, to the 10 milligram, they improve a little bit more. What about the bilirubin? Definitely there's slight improvement of the bilirubin in the 5 and the 10 milligram compared to placebo. And when you take placebo and you put them on the treatment, they improve their bilirubin, even if their bilirubin at the beginning was not significantly abnormal. Other criteria, including the ALT, the AST, on the 2 upper panels, the total bilirubin, the conjugated bilirubin, and the GGT, and the same pattern, and the ALT and AST, same pattern. Once you start these treatments, these numbers improve. 2 other markers of immunity and inflammation that were presented in the publication by Nevins in the New England Journal of Medicine 2016, looking at signs of immunity, particularly the IgM decreased in the patients who got OCA versus the IgA and the IgG. The IgM showed a drop. These criteria for or markers of inflammation decreased from the baseline in both groups who received the 5 and the 10 milligrams. So looking at the CRP, looking at TNF alpha, looking at IL-12.
Hold on one second. Continue.
What about lipid values? Slight improvement in the lipid values, whether you consider total cholesterol in the lower panel and triglycerides versus the upper panel that shows the high density lipoprotein and the low density lipoprotein positive effects of these drugs. How did patients tolerate the medication? So the adverse events are shown here in this table. Pruritus was an issue, more in the 10 milligrams than the 5 milligrams, and in the 5 milligrams a little bit more than the placebo. But in respect to headaches and fatigue and nausea, not too much difference from placebo. What about pruritus? And you can measure pruritus by the pruritus VAS score over time, and you can see here with placebo, you're giving them nothing, there's no pruritus issue, but when we use the 5 milligrams, there's slight increase in some of the patients presenting with pruritus. It's less than 10 milligrams, but they get closer to each other between the 5 and the 10 by month 6. And again, if you drop, over time, patients tend to show less pruritus and more tolerability to the treatment. And this is important in the overall findings of the POISE study. So the overall findings are summarized here, that the effect of OCA was consistent, independent of the age of the diagnosis, the duration of the disease, or the base alphas. Titration from 5 to 10 milligrams, so going from 5 initially, then increasing it to 10 milligrams a day, based on the response, the clinical response and the biochemical response, helped to improve the tolerance, minimize the dropouts due to pruritus, and showed comparable efficacy of the 5 and the 10 at 12 months. Thus, starting the patient on 5 milligrams of OCA with titration to 10 milligram based on the clinical response appears to be an appropriate dosing strategy. So is OCA given to individuals with PBC with an inadequate response or unable to tolerate ursodeoxycholic acid produced a significant clinically meaningful improvement in liver biochemistry, which has been shown to correlate strongly with the clinical benefits. So just the FDA has approved obeticholic acid, OCA, for patients with PBC in combination with ursodeoxycholic acid in adults with an inadequate response to UDCA, or as a monotherapy in patients who are unable to tolerate UDCA. The long-term management of the patients are very important. Just to remind you, with the AASLD guidance or the guidelines, we routinely see these patients every 3 to 6 months and test their liver enzymes. We measure, being an autoimmune disease, we keep an eye on the thyroid status and measure TSH on annual basis. We talked about this as a disease that affects the bone mineral density, and we use DEXA scan, and we repeat the DEXA scan every 2 to 4 years. Since it is a cholestatic disease, it interferes with the absorption of fat-soluble vitamins, and accordingly, we monitor patients for fat-soluble vitamin deficiencies in the setting when they have advanced cholestasis. As routinely recommended, an upper endoscopy every 1 to 3 years if patients have cirrhosis or their Mayo risk score over 4.1, or if they have a platelet count less than 140,000. We routinely do the ultrasound with or without alpha-fetoprotein every 6 months in patients with known or suspected cirrhosis to monitor for hepatocellular carcinoma. Thank you very much for your attention.
All right.